Hi, welcome back. I'm Eric Vanderlip, an assistant professor at the University of Oklahoma School of Community Medicine and Medical Informatics, Psychiatry, and Family Medicine. And this is webinar number 2, the first of our 3 webinars on the chronic care model. When we left off last time, we were talking about integrated care. And we discussed the process of integrated care being a two-way street, bringing behavioral health services to primary care settings, primary care services and access to primary care treatments to behavioral health settings, because the two are different in our current healthcare system. And then we talked about the fact that integrated care is a continuum. And some of the more successful models of integrated care have been built upon this chronic care model. And that's one of the things we've got to get to today. But before we get there, I want to shift gears a little bit and backtrack to zoom out to the moon and look at what's happening across the United States and across the world in terms of how we're changing, how you and I are changing, how our grandfathers and grandparents are changing, and how our younger kids are changing, and looking at what they're dying of. That's what we're going to be focusing on for just a second, so bear with me. So we'll be talking today about this global burden of disease phenomenon, chronic care systems, and the shifting landscape of healthcare, because it's shifting out beneath our feet. And we have to talk about why. So Epidemiology 101, stick with me for a second. There's a concept or a construct called disability-adjusted life years. A disability-adjusted life year means that if I die from a heart attack at the age of 55, like somebody with SMI might from our last lecture, and I was going to live until the age of, let's say, 75, I've lost 20 years of productive life. That's one thing due to mortality. But there's another thing where if I have a heart attack and I die at the age of 65, but I've not been able to work because my heart's not pumping oxygen to my brain and I can't focus, or I'm too weak to get up and do the work that I used to do for 10 years until the age of 65, then I'll have 20 years of disability-adjusted life years. So 20 years of productive life lost, it's a combination of 10 years of mortality plus 10 years of disability. That's a DALY, or a disability-adjusted life year. And it's a common metric that we as epidemiologists can take a look at our population and attribute causes of death and disability from disease to try and figure out what are the leading diseases that are most hurting our populations. And it's a combination, like I said, of death and disability. So not just death or mortality. If we just look at mortality, it doesn't really account for the economic burden of disease and the other aspects of disease that rip us away from our lives. So something like schizophrenia will have a much larger DALY, perhaps, than some other diseases that strike later in life. If we are to look at the United States, this is from the Global Burden of Disease study, and these are researchers up at the University of Washington that lead this march to try and identify what these leading DALYs are globally, not just here in the US, but globally, through fancified surveying metrics and outcomes databases and public reporting databases. They've divided up the totality of morbidity into 3 main things. They look at infections, or infectious disease, infectious illness, which is red. They look at green stuff, which is road injury generally, trauma, not mental trauma, but physical trauma, falls, road injury, gunshot wounds, knife stabbings, murder, violence. And then they look at the blue stuff, which they term non-communicable illness, things that we can't transmit to another, but yet lead us to die. Things like congestive heart failure or ischemic heart disease. That's IHD. That's at the top right corner of this graph. And this graph, all these squares, represent what's actually killing people in proportion to the total number of DALYs for a population, or disability-adjusted life years. The bigger the square, the greater proportion that disease has for morbidity and mortality in our population. This is what the United States looked like in 1990, 26 years ago. You can already see that here in the US, we're doing pretty well with infection, disease from pathogens. We're doing all right with road injury. The thing that's primarily killing us is non-communicable illnesses, killing us and disabling us. Things like back and neck pain, and other musculoskeletal, pretty big. Ischemic heart disease, stroke. Here's the stuff on depression, schizophrenia, bipolar disease, alcohol use disorders, and substance use disorders. This is the US in 2013. And you could tell there's a difference, a subtle shift. So if you flip between the last slide, 1990, and 2013 here, you can see that the chronic illnesses, non-communicable illnesses, are pushing out these other things. The green stuff, the red stuff. Those things are getting proportionally smaller because we're getting on top of it. And even though we talk about Zika virus and Ebola and all these other things we're scared about, we're getting on top of those sorts of things. We're not getting on top of several other things. One thing we're not getting on top of, right here in the middle, diabetes. I just want to point that out. Let's look at another healthcare system, a completely different system from around the globe. The United Kingdom, where they have a single payer system. What do they look like in the 1990s? Well, here, compared to the US in 2013, they've even got less road injury, less infection. What they're not doing a great job with is managing all this stuff. And this is the UK in 1990, non-communicable illness. But if we fast forward another 25 years, it's the same trend. You can see slight changes and a reduction in the overall burden of infectious disease and physical trauma, injury, to the overall mortality and morbidity burden of that population. So in the UK, where they have a single payer system and it could be working all together, the growing problem, literally growing problem in proportion, is this non-communicable illness. This is a totally different country in 1990. Can you guess what it might be? It's not the UK, it's not the United States, but it's a place that really hasn't grappled or conquered infectious disease. Maybe because the sanitary conditions aren't as good, or the basic vital infrastructure of housing supports and shelter and food security aren't quite as good. Here's this country 25 years later. Same trend. You see what I'm saying? They are getting on top of infection, trauma, and injury as leading causes of morbidity and mortality. And now they're getting left with non-communicable illnesses. The ratios are different, but the trend is the same. This country, by the way, India. Tons of people, huge new populations, blowing up in terms of their non-communicable illnesses. Put a different way, this graph shows us some of the risk factors leading to those outcomes. So rather than looking at it like ischemic heart disease or suicide or physical injury, this divides up these categories into risk factors, into three main risk factors. Behavioral risk factors, something like alcohol use disorders, metabolic risk factors, and environmental risk factors. Whenever there's an upside down U on this graph, that means the two are combined. So if you look at everything with a B in it, that's this, and this, you could see that behavioral risk factors account for the vast majority of these outcomes in developing countries and in the US. This is a global phenomenon. The way people behave, their choices they make in their exercise, their diet, are what's leading them to die. That's not what was happening in 1907. In 1907, we had a different metric. We had something much more similar to India in the US. We had problems with tuberculosis and infectious disease. And this is a picture from Denver General Hospital, I just found it online, of a tuberculosis ward in 1907. This is around the same time that modern American healthcare was developing. We were coming up with reports like the Flexner report that said, this is what healthcare education and medical education needs to look like and how we should standardize it. And these were the scourges at the time that we had to wrestle with. Tuberculosis at that time, and tuberculosis now, is an infectious disease. It is something that is curable. It takes a while to cure it, but it's curable. And as soon as we get on top of it and we've cured it, we're done. Acute and episodic illness is what our healthcare system grew up on. Grew up on in terms of a payment mechanism and resource, grew up on in terms of a treatment mechanism and ethics, and it's what it grew up on in terms of how we work and how we're designed to work. When I, as a clinician, see somebody face to face and I make a differential diagnosis and I reason out what I think is probably most likely the cause of their complaints, and then I order laboratory tests to confirm that or deny it, I'm using this scientific method to arrive at a diagnosis that then I can apply a cure for or a treatment for. That is very important with acute and episodic care. Less important for chronic disease management. But this is what we know in our healthcare system, and it's still what we teach to today. In this system, the healthcare system, we react to catastrophe. We're crisis managers. Somebody falls and goes boom. We have to Humpty Dumpty them back together. That's what we're used to doing. That's what we're used to doing in behavioral health too. We have psychiatric wards, inpatient wards, and acute emergency services and detox services for people who have hit the wall with crisis or their behavioral health conditions or substance use conditions. When we react to catastrophe, we're basically functioning like a goalie. And if you will with me for a second, we're basically just trying to prevent the proverbial puck from getting in the proverbial goal. And we're always playing defense. It's really hard to ever get in front of the game or to ever win the game because we have no offense. We have no way to get out there and prevent the puck from even coming to us in the first place. And what we do is we quickly get overwhelmed with lots of pucks coming in to see us. We've got to think differently about how we design ourselves, how we design our systems, so that we can get ahead of the game a little bit. In fact, we might want to take the example of hockey and ask one of the biggest players in hockey ever, what would Wayne Gretzky do if he were in charge of this problem? Would you just have a goalie and defense, or would you want to think it differently? You might ask yourself, and this is a quote, what would Wayne Gretzky do? He'd say, I skate to where the puck is going to be, not where it's been. So where is the puck going? You know that already. The puck's going towards non-communicable illness. That's where our society is shifting. As we get on top of all these other things, tuberculosis and X, Y, and Z, we're left with these things that we can't cure, that we don't transmit to each other, that are predicated on diet and lifestyle and behaviors, and that have to be managed because we don't have a cure for them. We have to manage them. That's a fundamentally different approach and something we as a society and as a healthcare infrastructure have never been able to really grapple. This is where the puck is going. This is the lexicon of healthcare reform. Look at all these buzzwords that we have nowadays in healthcare. And I'll get to the tie-in to behavioral health in a minute. But this is what people are talking about nowadays. Some of you may be undergoing training to be part of a behavioral health home. Oklahoma is one of many states that have had initiatives to reform our health services for those with serious mental illness and kids, adults with serious mental illness, kids with serious emotional disturbance. You may be part of a team in a behavioral health home. That's part of this transition in our healthcare system to frankly manage chronic illnesses. There's other things. The patient-centered medical home is huge. It's all the rage in primary care. You've got co-located care like we were talking about in our last webinar. Self-management support, an integral part of today's medicine. Health literacy, training people so that they can understand the nuances of their disease and manage it themselves. By the way, that's also called recovery in behavioral health parlance. We've got cardiovascular disease, health behavior change, patient-centeredness. In an episodic healthcare system, you don't have talks about patient-centeredness and shared decision-making. Because, to take an extreme, if I've been in a car accident and my pelvis is shattered and I need to have it sewed up and I'm losing blood a lot and my blood pressure is 60/40, I'm not getting enough oxygen to my brain and I don't really have time to sit down across a table with you and make a shared decision about whether or not I need my pelvis sewed up. We as a healthcare system have to react. And that's an acute and episodic care system. We're good at that, being paternalistic. What we're not good at is managing chronic illnesses, where the relative threat of death or dismemberment or life and death is not in the balance as much. And people need to be informed in their care because they're the ones who have to manage this thing over time because we don't have a cure for it. There is a book that is out there, and maybe some of you have read it. It's called The Biography of Cancer. And it posits that as a medical system and the science of medicine, if we as a system and a science of medicine can get on top of cancer, the emperor of all maladies, then we'll have done the biggest, hardest challenge in all of medicine, in the science of medicine, in conquering the body's own inability to regulate itself. But I actually think that based on our current epidemiology, we're getting on top of cancer. Science has given us amazing new breakthroughs to think differently about how we address oncologic illness and get it under control so that people are living longer who've had diagnoses of cancer. It's still one of the leading causes of death in the US and will be one of the leading causes of death globally. But I actually have a different take. I think the emperor of all maladies in today's society is not necessarily cancer because we're discovering some cures for it. The new emperor of all maladies is something as banal as diabetes. In fact, diabetes isn't really as much a malady as it is the quintessential chronic disease. Which brings me to this. This was the point of our entire webinar here, was to present to you the chronic care model. Let me tell you a little story. The chronic care model started when a group of healthcare service researchers were looking around the country trying to figure out the best way to manage diabetes. And this happened in the 1990s, where they first thought about this. We already knew, as you saw from that graph before, in 1990, diabetes was a serious cause of morbidity and mortality amongst our populations. And as you know, as recently as 2013, it's grown in terms of its overall importance in our disability and mortality in the US, globally as well. So they looked around at all the evidence-based literature and they culled from it every bit of goodness to managing diabetes. They threw out all their assumptions and they put together a new model for managing it. It's analogous to somebody taking a spark plug and a piston, a transmission, a steering wheel, windshield wipers, and putting together the first automobile, first internal combustion engine. It's not a car like we see it today, and it's not even a car for mass production per se, but it's the framework of an internal combustion engine. They did this in the 1990s, and they published it in Journal of the American Medical Association in 2002, but it had already been around for 5 to 7 years at that point. Our next talk is going to be about the evolution of this chronic care model over the next 10 to 20 years. And this slide shows you some of the most important things. In fact, if you took nothing away from the webinars that we're talking about, these 7 webinars, I would say you've got to know this. This is the most important thing that's fundamental to the structure of our new healthcare system, these 4 essential elements of something we call collaborative care, which is predicated on the chronic care model. So I want to go back to the chronic care model for just a second and focus on it, because that's the focus of today's webinar, or this webinar, I should say. So if you look at this, down at the bottom you get something, improved outcomes. That's the goal of all of our healthcare system today, to work in a way so that we have improved health outcomes. Not just a volume of services, or not just the number of things and widgets we can produce, but actually improved health outcomes for populations. The way you get to improved outcomes is you have 2 things. You have on the right, for you, a prepared proactive practice team, a team of providers that are prepared and proactive, not reactive, remember our goalie, and an informed, activated patient. Somebody who is literate in their illness, somebody who's maybe living in recovery, somebody who's able to manage their stuff on their own, and consult with a team of people, a team of providers to get an improved outcome. They have to have productive interactions. There's nothing in those productive interactions that requires a clinic or really anything else that as we know it in modern healthcare. Clinics and ERs and ICUs and hospitals are built for acute and episodic care. This prepared proactive practice team results from a redesign in how we organize our healthcare services. That's this blob, this teal blob on the right. And that redesign and organization of our healthcare services can be divided into three basic components. One, clinical information systems. That you as a healthcare provider have the right data and the right timing and the right infrastructure to know who your population is that you're treating and how well they are or not or aren't. You have to have a clinical information system to tell you that. You also need evidence-based care, aka clinical decision support. I need to know that if somebody's not doing well, I need to know what's the next step in their treatment. So that if I add that thing to their treatment, they will probably get better. Better likelihood than not that they will get better. That's clinical decision support. And then finally, we've got to redesign actually how you and I work together. And it doesn't need to be siloed people in offices. We've got to redesign systematically how we interact and how we work together and gel as a team to produce these evidence-based treatments for the populations. And then on the left, for an informed activated patient, you've got to have health literacy, aka self-management support in this model, because they have to know what's going on with them. If we always rely on us as a healthcare system to be paternalistic and tell them what's going on, there'll never be enough of us. So we've got to train and educate our populations so that they can learn how to do this themselves and get into this notion of recovery that we talk about in community behavioral health. And then finally, we need community, resources, policies, calorie counts on McDonald's menus, sidewalks on every street, so that people can have easy access to be able to choose wisely in their healthcare decisions. So in conclusion, I bring this up. This is a great quote from a very recent, just last week, article published in the Journal of the American Medical Association. In this article, they looked at a large healthcare system's integrated care initiatives called Intermountain Healthcare in Colorado. I think it's in Colorado. I can't remember exactly. Sorry. Doesn't matter. Point is, large healthcare system blended its behavioral health and primary care services. They followed many of the tenets of the chronic care model. And this quote talks about how these models can be used towards measurement-based care, which is one of the essential components of collaborative care, which we'll be talking about at our next webinar, and value-based reimbursement, which is where we're going in the healthcare system. We'd like to not just pay for you as a healthcare provider to produce widgets, aka also known as just seeing people over and over again. We don't want you to see them any more than you need to produce a good outcome. What we want to pay for is outcomes. That's value-based payment in healthcare. And Thomas Schwenk, who wrote the editorial to accompany this large-scale analysis of this integrated care system, says, the most significant consequence, however unintended, of outcomes-based medical care and value-based reimbursement may be a profound change in the fundamental structure of the U.S. healthcare delivery system. These things, the way we pay for our healthcare services and the way we measure our outcomes, could result in a profound change in the way we work. These are essential elements that really are mainly possible through the chronic care model and collaborative care. It's what we've got to move to. It's where the puck is going, and it's also the end of this webinar. Thank you.